Hello, my name is Heather Hoops. Thank you for taking the time to listen to this talk on gender bias and stereotype threats and how to address these biases to improve interoperative autonomy for trainees. I would also like to thank SAGES for the opportunity to present on this very important topic. I have no conflicts of interest to disclose. This talk focuses on gender-based disparities in operative autonomy. However, I would like to acknowledge that other biases, such as those based on an individual's race, ethnicity, religion, or sexual orientation, may also play a role and often intersect with gender-based biases to further influence an individual trainee's operative autonomy. While also extremely important, disparities based on differences other than gender are outside the scope of this talk. Autonomy is a critical aspect of surgical training and is required to produce graduates who are ready to enter practice. The dynamics within an operating room are complex, with operative autonomy influenced by a variety of faculty-related, trainee-related, and environmental factors. From a faculty perspective, factors such as number of years in practice and comfort level with the case being performed can affect trainee autonomy. For trainees, skills and attributes such as knowledge of the case being performed, as well as technical skills, may affect the level of intraoperative autonomy they are granted. And finally, environmental factors such as case complexity or the time constraints of the operating room schedule can also influence the level of trainee autonomy. One main research question that multiple studies have sought to answer is whether gender plays a role in how much autonomy a surgical resident or fellow is granted. In this study, gender-based differences in operative autonomy were evaluated among 33 thoracic surgery residents and fellows at 7 different institutions using the Swiss scale. This study found that female gender was associated with decreased levels of autonomy for both faculty and resident perceptions. In this study, also using the Swiss scale, gender-based differences in intraoperative autonomy were assessed among 412 general surgery residents across 14 institutions. This study found that female gender was associated with lower levels of operative autonomy, with male residents receiving more passive help and supervision only, and female residents receiving more show and tell help and active help. This study evaluated gender-based differences in operative autonomy among 106 general surgery residents at a single institution using procedure feedback forms. Female resident gender was significantly associated with less intraoperative autonomy than male gender, even after controlling for confounding factors such as case complexity, PGY level, and attending gender. These gender-based differences in autonomy were most pronounced at the PGY3 and PGY4 levels. These studies demonstrate that evidence of gender-based differences in operative autonomy exist across different surgical subspecialties, multiple institutions, and utilizing different autonomy assessment tools. Potential sources for these gender-based differences in autonomy include implicit bias, gender-based differences in confidence levels, as well as differences in the perception of autonomy among residents and faculty members, which also are subject to gender-based differences. This study sought to determine the prevalence of implicit bias among the greater health professions community as well as among surgeons. This study utilized implicit association test data from Project Implicit to determine the prevalence of implicit bias among healthcare professionals. They also solicited volunteers of residents and faculty at the American College of Surgeons meeting to recruit 131 surgeons to complete implicit association tests. They found that both healthcare professionals and surgeons possess implicit bias towards associating men with career and women with family. Surgeons also possessed implicit bias towards associating men with surgery and women with family medicine. So what effect do these gender biases and associated gender stereotype threats have on trainee performance? In this blinded randomized study of 131 residents across 3 institutions, residents were recruited to evaluate the effect of resident performance on FLS tests before and after a gender stereotype threat or gender stereotype protection. Residents were divided into each group randomly in a one-to-one fashion. Residents in the gender stereotype threat group were given literature that stated that female residents perform worse on FLS tests than male residents. Residents in the gender stereotype protection group were given literature that stated that females perform the same on FLS tests as compared to male residents. And the results of the study showed that male and female residents had the opposite effect to the stereotype threat. So women in the stereotype protection group, who were given literature that stated that women perform the same on FLS tests than males, performed better on FLS tests after giving stated literature. However, women in the stereotype threat arm, as depicted in the blue dotted line, after given literature that stated that women perform worse than male residents, showed a decrease in FLS performance after reading the literature. However, the effect on males was opposite. So males who were given the same literature that stated that females performed worse on FLS tests had a perceived advantage and performed better on FLS tests. However, males performed worse on FLS tests when given literature stating that they did not have an advantage over female residents. Another important consideration is gender-based differences in perception of autonomy. Recall this study evaluating the effect of gender on cardiothoracic trainee autonomy. There are significant differences in perceived autonomy between female residents and faculty members. The differences in perceived autonomy between residents and faculty are much smaller in their male counterparts. For example, thoracic surgery faculty perceived meaningful autonomy granted in over 30% of cases, compared to female residents perceiving meaningful autonomy in only around 20% of cases. So how can we reduce gender-based differences in operative autonomy? Interventions on a trainee level can be enacted to help reduce gender-based differences in autonomy. All trainees should undergo implicit bias training, which will help them be more aware of implicit biases that exist, as well as to develop strategies to help counteract some of these biases and stereotypes. Additionally, trainees should be provided more counter-stereotype exposure to women leaders in surgery. This can be either via mentorship and sponsorship arrangements or by increased exposure from visitor professorships and grant round lecturers. And lastly, programs to identify and address resident confidence issues may help residents better match their confidence and competence, which also may help resident autonomy. The next are faculty level interventions to help reduce gender-based differences in autonomy. Faculty are key to help change the culture for the next generation of surgeons rather than propagate outdated and discriminatory practices. Faculty should all receive formal training on procedure-based teaching. This training can help faculty provide structured feedback using individual specific observed behaviors rather than generalizations that can lead to more stereotype biases. And lastly, all faculty members should undergo implicit bias training to increase their own awareness of their own implicit biases, as well as to develop strategies to counteract some of these stereotypes and biases. Implicit bias training first seeks to introduce the concept of implicit bias to improve awareness regarding the prevalence of implicit bias, as well as increase literacy regarding the terms used. Implicit bias training also provides strategies to help overcome some gender stereotypes and biases, as well as some strategies to avoid that are not helpful. Studies have shown that a single 20-minute to 2-hour educational session has been shown to improve implicit bias awareness, as well as self-efficacy to engage in gender equity promoting behaviors. Program level interventions are also important to reduce gender-based biases among trainees. First, it is important to assess gender bias within the department using implicit association tests or other forms to help determine a barometer of the culture within a trainee's program. Second, it is vital to analyze and measure trainee autonomy data to determine whether any gender-based differences in autonomy exist. This data can be used to improve transparency and accountability within the department. For example, if a faculty member consistently provides one gender with more autonomy than another gender, this could be the basis of additional educational intervention or further disciplinary action. And lastly, independent raters of autonomy may help neutralize differences in the perception of autonomy between faculty and trainees. In conclusion, autonomy is essential to developing surgical graduates prepared for independent practice. Maximizing each trainee's autonomy requires identifying and addressing gender-based stereotypes. Reducing gender-based biases can be addressed through trainee level, faculty level, and program level interventions. Thank you.